Hello, everybody, and thank you for tuning into this episode of the Physician's Mind podcast. I'm your host, Curtis Wilkerson, and today I have a very special guest. I was honored to speak with Dr. Jeffrey Raskin. Dr. Raskin is an attending neurosurgeon at the Lurie Children's Hospital in Chicago, and he's also an assistant professor of neurological surgery at the Northwestern University Feinberg School of Medicine. If you enjoyed this episode, please share on Spotify, Apple Podcasts, or YouTube. Thanks a lot, and I hope you enjoy this episode. So, Dr. Raskin, I'm honored to have you on the show. Thank you so much for being here. How are you doing?
I'm great. Thank you for that introduction. It's a pleasure to be with you here this morning.
Absolutely. So why don't you just go ahead and tell us a little bit about who you are and what it is that you do for a living?
Yeah, I'm Jeffrey Raskin. I'm a pediatric neurosurgeon at Lurie Children's Hospital and associate professor of neurological surgery at Northwestern University Feinberg School of Medicine in Chicago, Illinois. I'm an associate vice chair of quality and safety for the Department of Surgery at Lurie Children's, and I sub-specialize in functional neurosurgery in children, which is the management of pain syndromes, movement disorders, and epilepsy. And so we can get into all of what that entails, but that's what I do here. And I trained, as you said, in Oregon Health and Science University is where I always start for residency, because that's where you start as as a surgeon. But of course, I went to medical school and got a master's degree, and before that, and then trained in neurosurgery, and then went to fellowship at Texas Children's Hospital in Houston, Texas. And then I worked 5 years in Indiana at Riley Hospital for Children, where I did functional neurosurgery mostly. And then I left there, and I've been in Chicago at Lurie Children's for about 3 years.
Phenomenal. So there's absolutely no shortage of experience there. Could you share some of your most common procedures as a neurosurgeon and maybe some of the more demanding ones that come on a less frequent basis?
Yeah, that's a good question. So I think any neurosurgeon, the most common surgery they do is shunt surgery, which is the implantation of tubes like plumbing for the central nervous system to alleviate hydrocephalus. So that's pretty much the most common surgery that any neurosurgeon does. And after that, I do, surgery on children for pain syndromes, movement disorders, and epilepsy. And so that includes the implantation of cybernetic devices with the central and peripheral nervous system to modulate pain or to alleviate epilepsy or movement disorders. And then I am building out this niche called rhizotomy, which is the cutting of nerve roots to decrease something called hypertonia, which is where the muscles are inappropriately activated by the central nervous system. So I do a fair amount of that surgery. That includes rhizotomy, which I just talked about. And I do a fair amount of surgical innovation in that space, which we can talk about. And then the implantation of devices really called a baclofen pump, a pump that is implanted in the abdominal wall with a catheter system that goes into the central nervous system space, the cerebrospinal fluid space, and delivers a medicine to decrease the activation of the muscles. Those are kind of the most common surgeries I do.
Incredible. So before we dive more into some of those nuanced procedures that you're capable of, can we just go back a ways and talk about when did you decide you wanted to go to medical school? At what point along your journey did you decide you were interested in a career in medicine?
I mean, it was very early on, and it's, I was the first person in my family to go to college, to complete college. My dad did go to a couple years of college, but wasn't able to complete them because he had a family and had to go to work. But I was the first of my family on either side to complete college. And it was really in high school where I decided I wanted to be in the medical field. And that had it had some variation early on. So I think most people do what they're passionate about, what they're mentored to do, and what luck affords them. And so for me, as a youngster, like a high school student, I was mentored by a neuro-ophthalmologist, and I thought that was fascinating. And so that kind of got me into that space. Also had a very good mentor who was an OBGYN, and I saw surgeries in the OBGYN space. And so I really wanted to go to medical school as a high schooler. But then in college, it really took the form of neurosurgery through some of the research I was doing on rats and learning and memory. And then I didn't get into medical school the first time I applied. So I went and got a master's degree and proved I could get A's. And then once I proved I could get A's, got into medical school, and the rest is history.
All right. So that kind of answered my next question about, did you always know you wanted to be a neurosurgeon? So you mentioned it kind of came to fruition as you were working in a lab with rats in college. Could you kind of explain a little bit more about that?
Yeah, I was a neuroscience major at Pomona College. Neuroscience was a brand new major, multidisciplinary sort of hodgepodge of different classes across multiple disciplines. And I loved it. It was awesome. And I was doing research in Dr. Karen Parfit's lab on learning and memory, specifically something called long-term potentiation. And it involved trying to rescue long-term potentiation, LTP, in old rats by perfusing a certain medication over their hippocampal slices. So it went, decapitate the rat, dissect the hippocampus, slice it out into 50 micron thick slices, and then perfuse it with artificial cerebrospinal fluid in a humidified oxygenated chamber, keep those slices alive, and then use microelectrode recording from CA1 and CA3 regions of the hippocampus to identify LTP and then augment that signal. And the most exciting part was the surgical part up front. You had to do it in less than 5 minutes or the slices were not viable. And then the recording part, though interesting, was not the most interesting to me. So I decided, at that point, like surgery is definitely what I need to be doing, and not necessarily like PhD work or anything like that.
Right. And so, given that you knew you were interested in neurosurgery in college, did you start medical school knowing how competitive and difficult it would be to match into a residency for that?
I did. Yeah. Yeah. I mean, it's a very difficult course. Like, it's very hard to get into neurosurgery. It's very competitive. It is not the hardest discipline to get into because the quality of life is not necessarily what you would get if you were a dermatologist or, an ER doctor has a very nice quality of life when they're not at work. But neurosurgery, I personally think is the pinnacle of modern medicine and the most fascinating area. The integration of technology with the central nervous system and the peripheral nervous system is just unmatched in any other discipline.
Agreed. Agreed. A high level of complexity there. So could you share a little bit about, well, and before I ask you this question, if I read your CV correctly, you had 99th percentile scores on both step 1 and step 2, right?
That's right. Yeah. I mean, I think that is important. It is important to have very good board scores. Nowadays, the step 1 is ungraded, it's pass fail, and the step 2 is still graded. But yeah, you have to be extremely competitive from a board score perspective, and then you have to have research. Now, actually, the number of things that you have to have as a matching neurosurgical resident is huge. It's 37. Research products like talks, posters, papers, and so on. And so that wasn't the case when I was coming up, which is good because I didn't have that many publications or, work product dissemination. But you have to have that. And then you have to have letters of recommendation from people in the field who vouch for you. You have to have gone to different institutions and worked there for usually a period of a month to show that you can keep up the pace. It's very militaristic training. So these residency programs are 7 years, which is among the longest. And that's like longer than most marriages. So you really want a goodness of fit between you and the program you're going to. And so that is really actively pursued across the nation in the around 100 neurosurgical training programs that exist.
Sure. So how did you set yourself up for success throughout medical school? Did you have any particular habits? Were there any challenges you had to overcome that are worth sharing? And perhaps any networking skills that you gathered that you would like to share with the audience?
Yeah, now these days it's really easy to reach out to surgeons, to go to like the AANS, American Association of Neurological Surgeons, and the Congress of Neurological Surgeons. These are two societies that really welcome young people, like even starting in college. And you get a flavor for what neurosurgery is and what it isn't. it is a very difficult field to be in, and it takes a certain personality type. So that sort of like early understanding is critical. You don't want to get into your second or third year and say, this isn't for me, I want to do something else. I mean, that's certainly fine, and plenty of people do it, but it's better if you know beforehand. So that sort of thing, like educating yourself about what it actually is. And then producing, research and getting involved, reading the literature, that sort of thing will really help you have a good understanding what you're getting into and also actually get into neurosurgery.
Right on. So, what was your residency like? Perhaps some of the most difficult parts, some of the most memorable, and maybe some of your proudest moments. I know neurosurgery is one of the most notoriously grueling residency programs. So, could you please share with us a little bit about your experience?
Yeah, I always quote this movie. I can't remember which movie it is, but it's a pride-swallowing siege that you can never fully tell anyone about. It is a transformative experience, I would say. There's nothing that can prepare you for the rigor of neurosurgical training. But the closest thing to it is it's like very militaristic in training. There's a clear hierarchy, and that's for safety. That's for disseminating patient care. And it's a learned autonomy over time. That's not to paint it as totally bad. It's very, very good. It's awe-inspiring to really think about taking people who really don't know anything about medicine. When you graduate as a medical doctor, you know exactly nothing about giving care to people. And so taking those people and through experiential learning and didactics, transforming them into independent, competent neurosurgical practitioners is like probably the best part of my job. And I'm always fascinated that it works. I mean, you see these residents that come in as like ones and twos, and they can barely work their hands. And you can almost see them myelinating pathways as they learn these procedures and stuff. And they come back to the children's hospital later, and they're just adept. They have capabilities and so on. And so that's kind of what my training was like. There are terrible parts. I mean, you make mistakes and it leads to patient death. You make mistakes and it leads to patient illness. But if you're always trying your best and your trainers, like your mentors, believe in you, then you can assimilate that psychological trauma and get better each time. And so that certainly happened to me. Those are low points when you hurt people and you didn't mean to, but you're doing real things. They say neurosurgery exists on the precipice between opportunity and disaster. And that is basically where we operate, right? Very sick people, or sometimes not so sick people, we're trying to do things to improve their quality of life, but they have real life consequences and risks. So that sort of psychological trauma can accumulate over time. And then to answer your question about good things, I mean, I would think looking back on residency, it might be through rose-colored glasses now that I'm 8 years out of fellowship, 9 years out of residency. But I would say when your faculty sort of invite you back to do things or look to your expertise, when they basically say good job, right? Those are really rewarding parts because you realize that you kind of made it to their level.
Wow. Wow. So when you were in the earlier years, how did you cope with the idea that you had, 10 more years of training before you finally reached your goal?
Well, I mean, my philosophy about really everything is that goals are great. They give you direction, but the journey is the whole thing, right? I mean, if you just keep worrying about a goal in the future, you never really get to experience what you're going through now. And there is value in everything that we do. So for me, it wasn't necessarily ever like, I can't wait to graduate. It was, I'm gonna every single day show up and learn something and have some fun. And, they say that the days are long, but the years are short. And I think that's pretty true. You also don't have a whole hell of a lot of time to reflect on how long it is. You're just busy constantly. It's a culture of immediacy. Everything needs to be done right now, which is like a lot of amygdala stimulation. And so, it kind of involves your limbic system a lot and suppresses your prefrontal cortex and your logical sort of abilities. And so it's not really ever, I don't know, for me, it wasn't necessarily like, God, I can't wait to get to the next step. It was like, yeah, this is cool. I can't believe I could do this stuff.
Interesting. Yeah, there's plenty of Eastern philosophy that says your degree of well-being is directly correlated with how present you are. And certainly in medicine, it's like you just have to embrace the journey and be present at every moment that you're working. And that's, a very good philosophy. I think that's fantastic.
It has to be that way because otherwise you inappropriately anchor on like when I graduate, everything's going to be perfect. And that is not the case. So don't do that.
Right. Well said. Well said. So, what was your reason for pursuing pediatric neurosurgery, specifically
Mhm.
in adult neurosurgery?
Yeah,
That's
we train basically 6.5 years on adults and half a year on kids in our neurosurgery training. And then to be a pediatric neurosurgeon is one additional year. And that's because there's a tremendous number of surgeries that we do on kids only that is not a surgery in adults, like craniosynostosis, reshaping the skull. That's a huge area of craniofacial surgery that we do that is not done in adults. And so you need extra training to do that. And also the physiology of children is totally different. We take care of fetal patients, right? Fetal surgery to 20 to 25 week premature babies all the way through basically adults. Like I take care of a fair number of cerebral palsy patients who are quote adults, right? They're 22, 24, 26, but they have movement disorders. And so that's the training. That's if you want to do pediatric neurosurgery anymore, you have to do a fellowship. Um, you are actually boarded in neurosurgery, which includes pediatric patients. But if you have a bad outcome or you're inappropriately operating on children, that's frowned upon significantly. So you have to do a pediatric fellowship. And for me during residency, I was chief of the Dornbecker Children's Hospital in Portland, Oregon, which just means I was a four. I had achieved the level of PGY4 and I was the chief. And so I had these really impactful experiences with patients, like a little American Indian boy who pulled a TV down on his head and crushed his head. And I thought he was going to die for sure, but he didn't. He lived and he did great. And his middle name meant champion. I cannot recall what it was in his native language, but it was his name personified through his illness and just amazing outcome. There was another patient I had who had a lethal brainstem tumor called a diffuse intrinsic pontine glioma, DIPG, and that's a death sentence. We don't know how to treat that, and people die very quickly. But he wanted to play Legos every day, so I would come in early before rounds, which is real early. Rounds start at basically 5:30, so to come in and play Legos with someone, you got to get up in the fours. And we would play Legos together for a period of time, and then I would go about my rounds. And I had very short interaction with him, but it really spoke to me about how kids are. And so it was the pathology of kids. It was also the fact that families are involved in a lot of people don't like that because the advocacy of a children's hospital, the advocacy of families brings another social dynamic that you don't really have usually as adults. Usually a surgeon talks to a patient and you communicate, you decide what to do and you do it. But in this case, with families around, they're very anxious. And it's a privilege to be able to take them through their highest point of anxiety, treat them effectively, hopefully, and then watch them kind of, live their life with this condition, but at least they're not quite so anxious. So those are the main reasons why I love pediatric neurosurgery and decided to pursue it.
Interesting. Very, very noble profession. So the next thing I want to sort of ask you about, something I've recently been reading on recently is near-death experiences among patients who have experienced cardiac arrest. And in this book, it's described as a patient being completely unresponsive, no heart function, no breathing, and effectively no oxygen being delivered to the brain. And once they're resuscitated, these patients, some of them, I forget the percentage, but they report experiences such as a sensation of leaving the body, a sensation of feeling at immense peace without any pain, and sometimes allegedly experiencing a 360 view of what's going on in the room, and in some cases being able to report what was going on during their resuscitation efforts. So I'm interested in understanding your perspective on consciousness from a neurological standpoint. Do you lean more towards a reductionist view where consciousness is seen as a byproduct of our neuroanatomy and physiology? Or do you consider a more metaphysical perspective where the brain might act as a receiver for some non-local field of consciousness, and perhaps share how your clinical and research experience has shaped your view on this topic?
Well, that's a sophisticated question. Yeah, so I mean, my views are going to be my own. I don't speak for anyone else. So our understanding of consciousness currently is that it is a combination of awareness and arousal, and that those two lead to what we call consciousness. And there are certain brain structures that absolutely have to be critical, including the ascending reticular activating system. Now, it doesn't have to be bilaterally represented. It could be unilaterally represented. So, for example, a patient who has a hemispheric stroke, or in some cases, like in epilepsy, where we actually remove half the brain, called hemispherotomy, those patients maintain consciousness. They are aware. They have normal arousal. They go to college. I mean, they're normal, right? With only half their brain. So it is not a full brain function to say it is. It can be restricted, and in many cases, like my cerebral palsy patients who have significant brain abnormalities, they can be conscious and aware, right? But if you injure both thalami, right, you have a single infarct of the artery of Percheron, which is this artery that branches sometimes and goes to both thalami in a very specific spot. If that one tiny artery is occluded, those patients never regain consciousness. So there is definitely a neuroanatomical requirement for consciousness. Okay. Now, when you get outside of, trying to understand metaphysicality of patients who are being resuscitated and report these things, I think that's totally possible. I mean, I operate on patients, sometimes they're on very light anesthetic regimen because I need to understand what their brain is doing. Like maybe I'm mapping their cortex while we're doing an epilepsy surgery. And sometimes those patients report awareness during surgery. And of course, that's never the goal, but that certainly happens. And so there's this idea that, yes, the brain is very complicated. We know very little about it. We know that we use all of it, not just 10%, but it is possible, even in the setting of medicines that are meant to dampen down consciousness, right? That's what they're meant to do. It doesn't always work. And so I think that there's a lot of logic and probably truth to these patients who are undergoing hypoperfusion from cardiac arrest and so on, but their brain is still functioning. And their brain doesn't die right away, and their brain is still functioning. And then they come back and they're like, whoa, that was crazy. I had all this sort of like awareness. Do I think that their spirit comes out in the corner of the room and watches everybody resuscitate them? I don't think that. But I think that maybe their other senses and maybe their imagination can fill that in. Those are my perspectives on consciousness. I really don't think that there's too much metaphysical in the world at all. That's my perspective. I think there are varying things we haven't yet proven or understood. So that's where I come from in my background to that answer.
Very interesting, very interesting, and thank you so much for sharing your thoughts on that. My next question is sort of, you mentioned how we do use all of our brain. Do you think that myth sort of stemmed from the revolutionary ideas of the subconscious mind, and maybe they were like, well, we only use 10% of our brain, meaning we're only aware of 10% of our function? Where do you think that misconception sort of arose from?
We could Google it, but if I had to guess right now, I think it came from brain mapping and this idea that there are dedicated areas of the brain that, for example, underlie motor function, the motor strip. There's the visual cortex and the occipital lobe that has a very specific job. But the vast majority of our brain has something called association cortex. which if you stimulate it, doesn't do anything, right? It doesn't cause your arm to jump, doesn't make your eyes move. But it is doing something, and it is associating all of your internal and external stimuli, basing it on past experience, predicting future events. So it's this area of it's a huge area of your brain, the majority of your frontal lobes that underlie this. And I think that my personal perspective is probably that we've known about this for a long time, right? People like Paul Broca started mapping the brain in the 1800s. So we've known like areas of the brain that do stuff, and then there's a huge amount of area that doesn't do things when you stimulate it. And I think that's probably where it came from, is we only use 10% of our brain.
Mm. So to make sure I understand you correctly, there's certain areas that are activated at certain times when we're engaged in particular behaviors, and that's where that misconception might have arisen from.
Right. Yeah. There's areas of your brain that are dedicated to function, and there's a huge amount of your brain that is not dedicated to function. It is association cortex. It can do a bunch of stuff. And by the way, it can take over if you have an insult as a very young child. It can take over for areas of your brain that were previously dedicated to something. Speech is one such example. And patients who almost everybody speaks from the left side of their brain. But if you take out the left side of a patient's brain because they have seizures, anywhere less than 8 or so, they'll regain the ability to speak from somewhere else in the brain. So this is a fascinating part of neurophysiology called neuroplasticity.
Absolutely. Yeah, that is extremely fascinating. And there was one story I read about, I forgot what the issue was, but there was a 3-year-old girl who had half of her brain removed, and they followed up with her, and she was completely normal. And it's
Yeah.
like amazing how that's even possible.
Yeah, cognitively, they can be totally intact, normal. I think that what you never really regain is hand function on the other side. So in the best cases, in the youngest patients, they can maybe, open and close their hand like that, but they never really regain dexterous movement, but they certainly can walk and talk and think and go to college and so on.
Wow. Okay, so the next thing I'd like to ask you, and pardon my ignorance on this topic, but from my understanding, human beings evolved with a purpose of survival and reproduction from a purely evolutionary standpoint. And what that means is that most of our behaviors were reinforced within our brain that were conducive to those goals of survival and reproduction, right? We were constantly seeking out better resources. We were seeking safer shelter. We were highly alert and aware of danger, and so on and so forth. And that was in primitive times when we were in an environment of scarcity. And now we live in the age of abundance with the same, effectively, neuroanatomical construction, if you will. And relating this to optimal productivity in humans in today's day and age, you see that I don't want, and I know there's some contention between calling it the reward system and the reinforcement system, I believe. So I'm going to call it the reinforcement system. There's almost a hijacking of our reinforcement system through the superficial and short-term pleasures that we have available to us, whether it's social media or alcohol consumption or drug consumption or what have you. And in order to optimize the reward system, reinforcement system that we've had since the beginning of our existence, would you agree with me if I said perhaps that it's more important, or it's very important, to visualize a long-term goal for yourself, whether that be a hyper ambitious career in medicine or business or law or whatever it may be, as an alternative to that short-term gratification, having a long-term goal for yourself and receiving the reinforcement through the progression towards that goal? Because I've also read that we only experience positive emotion in relation to progress toward a goal. So I guess to condense this down into a simple question would be, do you think that it's a valid way to take advantage of our evolutionary neuroanatomy by setting hyper ambitious goals for ourselves and taking advantage of the positive feelings we have along the way towards that goal?
Yeah. Well, I mean, there's certainly a psychological benefit to working towards a goal. right? Everyone has that. Everyone feels good after they clean the house, right? You don't want to clean the house, but you feel good after it. So, goal-directed behavior is critical. I mean, I think there's many layers to this question. Currently, there's this concept of the hedonistic treadmill, which is what we're always trying to like stimulate our reward pathway. And it's so easy these days. You go online and you scroll, and like our attention span is zero. And getting off of that hedonistic treadmill is critical. We all try to do it by reconnecting with nature, by limiting screen time, by camping, doing things that kind of disconnect us from the stimuli that are constantly ever present. And that's because of the huge success of the human condition, right? And then the other way to explain this, I think, is behavior has been defined as the overlapping of three ethics: autonomy, community, and divinity. And I think that, like, some archaeologists have been asked, when do you think like humans really started evolving, in an adaptive way where we just took over the earth? And it was she reaches back to this time where they found a healed femur on a skeleton. And that is weird, because why would you say weird? Why would you say a healed femur fracture was basically the beginning of modern human evolution, where we sort of became so successful as a species? And it's because of the sense of community, and because people were less autonomous. Like what you were saying, every question you asked me was about individual advancement, and didn't take into account community and divinity. And I think this sense of community is absolutely critical to sort of happiness and the progression of society in general. So I don't know, it's kind of a meandering answer, but
No, that is very interesting. I guess I did forget to include that. Yeah, we're social animals, and it is critical to have social connections. Yeah, that is a good point. Very.
and divinity, I've recently, because I am not a religious person, and I always consider myself not spiritual, but actually I'm pretty spiritual, and the sense of divinity exists all over the place. So I'll give you a couple of examples. In my life, meditation, I do meditate almost every day, and that is a sense of divinity. And then in the operating room, we all take off our street clothes, we put on different clothes, put on scrubs, we put on hats, we put on shoe covers, and then we cross this red magical line into the operating room space that's sterile. And that in and of itself is a sense of divinity, where we treat that space differently. And I think this is very interesting to just sort of observe across, all the different areas of your life.
Yeah, most definitely. I can't help but feel as though there's some indescribable aspect of existence that sort of unites everything together, and I have no basis of proof for that, and I'm not saying that to proselytize my beliefs, but that's just what I feel in some capacity. So super interesting stuff. Now,
Yeah.
going back to sort of our discussion for medical students and advice in that regard, we may have a medical student or undergraduate student perhaps who's listening to this and is looking for some advice from someone who's really made it happen. So somebody who's interested in going to medical school, or perhaps is in medical school interested in matching into a competitive specialty, what advice would you have for them to be successful in their journey?
So I would say you really need to know what you're getting into, as much as you can. And then I would look to the people who are doing it and see if you vibe with them. Like, is that who I want to be? Is that the life I want? And then just work hard. Realize you're not in competition with everybody. You're only in competition with yourself. And if there are limited spots, like in neurosurgery, there are limited spots, not everybody matches. That's okay. You can try again. But if you make it, it is an incredible, rewarding experience that will change you fundamentally as a person, but you will benefit from.
Great advice. Great advice. Work hard, find the people that you vibe with, and just
Yeah.
determine what do you think is going to be the best for you.
From
But
like a how do you do it though, you need like as a medical student, you need letters of recommendation. You need to rotate at places so you can show them, you know, who you are and how you approach things and how you think and if you're reliable. And then you need research dissemination products. There was a recent manuscript published with how many research things did the matching residents have. In neurosurgery, it's 37, which is an incredible number, but you need posters, presentations, manuscripts, and then you need good board scores. You need to show that you have the capacity to absorb the massive amount of information in neurosurgery um, and then be able, to accomplish the goal, which is to be a independent and competent practicing neurosurgeon.
excellent. So on that topic of, mastering the learning process, as we sort of wrap things up here, do you have any advice or tips based on what you know that would be conducive to somebody maximizing their ability to study effectively and learn such a massive amount of information so quickly? Maybe some strategies that were good for you along the way, or some that you know to be beneficial.
Yeah, I don't know if there's any broad like answer to that. I think everybody learns in different ways, right? There's experiential learners, there's visual learners, there's auditory learners. Some people benefit from being in class constantly. Some people benefit from being at Starbucks and just reading. That was me. I hardly ever went to class. I went to Starbucks and just stayed there 12 hours a day and read and made notes and stuff. However, I mean, as a medical student, you know how to learn. It's another step up. And so I would dance with who brought you, do what you do, and assimilate that information. It's also good to, bounce these ideas off other people. I know, like group learning work is very effective. I would recommend that a lot. And it also gives you different lenses and perspectives that people come from, allow you to look at a problem in a different way. That's very helpful.
Awesome. Well, Dr. Raskin, today, so far, we've talked about your journey along the way to medical school, when you decided you wanted to become a neurosurgeon, some of the ways you set yourself up for success in medical school, your experiences in residency, and some deep discussion about consciousness. So as we part ways here, I want to ask you one final question. In your time as a neurosurgeon, what was one of your most proud moments that you've had?
Yeah, I mean, there's so many. This is the opportunity. I think I already said this. Neurosurgery exists on the precipice of opportunity and disaster. So when you lean towards opportunity, it is a feeling of elation that cannot be duplicated. And that's part of the reason why surgeons, like neurosurgeons in particular, operate so long and so on. If you can limit the psychological trauma from the bad part, and you can maximize the benefit, psychological benefit from the opportunities where you save people and you change their lives fundamentally. There's no better feeling in the whole world. So that's happened to me many times, thankfully. I mean, so little children who come in with seizure disorders, and I implant a series of electrodes to find where their seizures are coming from, and then replace those electrodes with lasers and destroy that tissue. That happens frequently, and it's just the most amazing feeling to help patients. So there are many specific examples, but they're very complicated to talk about here at the end of this podcast. The other thing I would say that makes me really proud and happy is surgical innovation, where you identify a problem and then think about all of the different ways to approach it and then invent a new one. I've done that now a couple times, and it is a very rewarding part of the field, and I hope to continue to be able to do that.
That's incredible. Dr. Raskin, I feel like I could talk to you for another 2 hours, but we're about out of time here. So I just wanted to say thank you so much for speaking with me today and sharing some of your experiences and advice with us.
Yeah, it was my pleasure. Thanks for having me.
Absolutely. All right. Thanks again. Take care.
Bye.